I invite Dr. Ganga to present the second case. She is a second year DNB resident.
Good evening, everyone. Here I am presenting a case of Hirata is not a peaceful rice paddy. Here our patient, 38-year female, BMI of 31.65 kilogram per meter square, occupation as nurse, para-2, live-2, last childbirth 3.5 years back. History of GEDM and was on insulin during second pregnancy and not on any medication followed by that. She presented to our OPD with history of fatigue for last 2 weeks and recurrent hypoglycemic episodes for 4 days. And history of episodes of sweating, tremor, restlessness, hunger, giddiness and palpitation for 4 days. And she checked sugars during 3 episodes, which was in a range of 35 to 59 milligram per deciliter. And she gave a history of admission to local hospital for iron deficiency anemia and took iron injection and started on multivitamin tablets 1 month back. And history of diet plus workout started 2 months ago and she was on a low carb diet plan. And her each episodes of hypoglycemia was relieved by oral carbohydrate intake and maximum 3 episodes per day, mostly post meal. History of early morning and postprandial hypoglycemia. No history of similar illness in past, no family history of diabetes, and denied history of intake of any anti-diabetic medicines.
So at this point, like any differentials on, like when we sit in our OPD and patient come and say to us like hypoglycemic events. So what all events we think of, like why she got hypoglycemia? Any differential diagnosis or anything you want to say? Like what are the causes of hypoglycemia? No renal failure, sir. No. Yes, sir. Possibilities. So we put up some differential diagnosis for hypoglycemia. So we just list out the causes of hypoglycemia.
Most common causes of hypoglycemia are drugs, which is the most common cause, insulin or insulin secretagogues, alcohol, antimalarials, ACE inhibitors, ARBs, and hormone deficiency, cortisol, growth hormone, critical illness and sepsis, non-islet cell tumors like mesenchymal or epithelial tumors, insulinoma, non-insulinoma pancreatogenous hypoglycemia, insulin autoimmune hypoglycemia, malicious hypoglycemia, and post-gastric bypass.
So these are the few common causes not pertaining to this patient. These are few common causes of hypoglycemia. So this patient had both fasting hypoglycemia and also postprandial. Like after food around 3 to 4 hours, she started developing hypoglycemia, which has documented to 40 to 60 milligram per deciliter. So would like to think of any of the postprandial causes of hypoglycemia. So there are few diseases which causes postprandial hypoglycemia. As sir already mentioned, insulinoma is one of the cause. And any other? So we'll enumerate some causes of disease conditions which cause both fasting and some diseases predominantly causes postprandial hypoglycemia.
The causes of postprandial hypoglycemia include insulinoma, non-insulinoma pancreatogenous hypoglycemia, insulin autoimmune hypoglycemia, hereditary fructose intolerance, factious hypoglycemia, acute fruit poisoning, post-rods NY gastric bypass. And coming back to our patient, she was presented with acute onset recurrent hypoglycemia associated with the classical symptoms of neuroglycopenia that corrected by glucose, which means Whipple's triad positive. She had low blood glucose level and classical symptoms of hypoglycemia, and which was corrected by glucose intake. And we proceeded with, she was admitted under medicine department. On examination, her vitals stable, looking well, general and systemic examination within normal limits, routine blood investigation sent within normal range, RBS at time of admission was 68 and HbA1c was 5.5. And baseline ECG and chest X-ray done, no abnormality detected. Blood sugar level monitoring done in ward, recorded early morning and postprandial hypoglycemia, values ranges from 40 to 60 milligram per deciliter.
So after a general physical examination and investigations, we narrowed down our differential diagnosis to these.
Insulinoma, non-insulinoma pancreatogenous hypoglycemia, insulin autoimmune hypoglycemia, or non-islet cell tumor. And we proceeded with we sent serum random insulin level when we recorded a GRBS of 48 milligram per deciliter, and the random insulin level was found to be more than 1000, which means highly positive, with an elevated C-peptide 1772. And elevated serum insulin and C-peptide indicates a endogenous hyperinsulinemia. USG abdomen screening done normal, serum 8 am cortisol 14.8, autoimmune panel workup done negative, endocrinology consultation sought. After discussing with the endocrinology consultant, we did the next investigation which led to the diagnosis. And the investigation was levels of insulin antibody. Anti-insulin antibody was strongly positive, more than 100. And we diagnosed insulin antibody syndrome. Here the question is, why an young female developed acute onset of an insulin antibody syndrome? And we went back into the history once again and thoroughly checked the history and found that she was recently started on a multivitamin tablet from outside hospital which containing alpha lipoic acid. And we reviewed some literature which shows alpha lipoic acid can unmask insulin antibody syndrome in patients who are prone to that. We stopped the medication and treatment started with small frequent mixed meals. Patient better now with less frequent hyperglycemia, and now she was on regular follow-up. Here I would like to discuss the protocol that we follow in case of this patient, hypoglycemia evaluation. We had done a targeted investigation. Here the patient confirmed with hypoglycemia, Whipple stride positive, and she was found to have a serum insulin level more than 1000, hyperinsulinemic hypoglycemia, and C-peptide also elevated, which means she is in a condition of endogenous hyperinsulinemia. The three main differential diagnoses of endogenous hyperinsulinemia include oral hypoglycemic agent, insulin autoimmune syndrome, and insulinoma. Here the patient had serum insulin level more than 1000, which is mostly or always seen in insulin autoimmune syndrome. So we directly ran insulin antibody assay and found to be positive. And how to differentiate insulin autoimmune syndrome from insulinoma, I will discuss in end of the presentation. And here I would like to present another case who was under our follow-up, and patient diagnosed with insulin antibody syndrome, initial workup done elsewhere with a history of similar presentation. She was presented with history of early morning and postprandial hypoglycemia with elevated serum insulin, C-peptide, elevated insulin antibody titer. Initially she was started on small frequent meals, but her symptoms persisted and she developed multiple episodes of symptomatic hypoglycemia. Then we started her on steroids 1 milligram per kilogram and waited for 1 month. Even after 1 month of steroid, her symptoms persisted. She developed severe symptomatic hypoglycemia which requiring hospital admission and IV bolus of dextrose. And after reviewing some literature that show rituximab, which is effective in steroid refractory insulin antibody syndrome, and she was started on injection rituximab 1 milligram per kilogram dose and 2 doses 10 days apart given. Followed by the second dose, her antibody titer came down, frequency of hypoglycemia reduced, and she is better now on follow-up low maintenance dose of steroids. These are the reports that before and after treatment. Before the treatment, her serum insulin and C-peptide was grossly elevated with the positive insulin antibody levels, whereas after the treatment with rituximab, the levels came down and antibody titer level became negative. And discussion, insulin antibody syndrome, which was a rare disease and first described in Hirata in Japan and is also known as Hirata disease. Here the main mechanism is that insulin secreted after a meal which bound by autoantibody forming the insulin antibody complex, which causes an initial hyperglycemia due to decreased free insulin and results in more insulin secretion. When the antibodies saturate their capacity to absorb insulin, they suddenly dissociate and release large amount of insulin into the bloodstream and causes hypoglycemic episodes. And these episodes can occur any time of the day, fasting or postprandial. And some drugs and viral infection could also act as triggers, and the triggering factor include some of the drugs including alpha lipoic acid and viral infection. And the treatment, most of the cases are self-limiting and or only need frequent low calorie meals. if not responding to diet, we can start the patient on high dose steroids. Steroid resistant cases, immunosuppressants or plasmapheresis is indicated. And this is the main difference of insulin autoimmune syndrome from insulinoma. The timing of hypoglycemia in case of insulin autoimmune syndrome mostly seen postprandially, whereas insulinoma, most of the episodes are fasting. And serum insulin level are markedly elevated, that is more than 1000 in insulin autoimmune syndrome, and insulinoma moderately elevated. And this is the mechanism by which alpha lipoic acid, which triggers insulin antibody syndrome. Alpha lipoic acid and drugs having reducing properties which cleaves the disulfide bond between alpha and beta chain and causes linearization of the alpha chain, which results in exposition of the hidden fragments to antigen presenting cells and T lymphocytes and formation of the insulin autoantibody complex. And here the take home points are: if a patient presenting with hypoglycemia with a Whipple positive with elevated serum insulin and C-peptide, necessarily not be insulinoma. High serum insulin levels, that is more than 1000, always think possibility of insulin antibody syndrome. Hirata disease, commonly reported in Japanese population, could also be seen in Asian population. And insulin antibody syndrome is no longer a rare disease. Thank you.
I put Hirata is a Japanese word. I don't know the pronunciation, but Hirata it means a peaceful rice paddy. But I feel both of the patients with hypoglycemia presented to us were not peaceful, because whenever they get hypoglycemia, they get neuroglycopenic symptoms, and they're very anxious, that like a kind of impending doom or kind of thing. So these patients are very not peaceful. So I think why this name, but still Hirata is not a peaceful disease for anyone. Thank you. Questions?